Good afternoon.
Good morning for everyone. Welcome to the seminar. We will start in a minute. We have 100 colleagues from the region already in the room. Tenemos 100 colegas, más de 100
We
colegas.
already have over 100 colleagues in the room, and they continue entering. So I want to share with you before starting that this session is being recorded and also counts with interpretation into 2 languages, Spanish and English. Thank you. Before starting, this is information for all. It's the way you can listen to the presentations in your own language. You can select the language you want among the interpretation options in the lower right part of the screen. Select the language in which you wish to listen to the conference.
Select your language in the interpretation world in the back right. You can see interpretation, select your language, and we can start immediately. Muchas gracias.
Thank you.
Thank you. Thank you very much indeed. Vamos a comenzar
Let us then start with the opening words on behalf of Dr. Andrés de Francisco, Director of the Family Health Promotion and Life Course Department at PAHO, who has had difficulties to connect today, but requested me to give the welcoming words on his behalf. Welcome everybody to our website seminar using Syphilis for the elimination of congenital syphilis. We want to remind you that in 2016, the member states of PAHO committed to eliminate in the region the mother-to-child transmission of syphilis, HIV, hepatitis B, and Chagas disease by 2030. The vision of this initiative is to manage to have generation free of HIV infection, syphilis, and hepatitis B and Chagas disease starting in 2020. Unfortunately, in spite of the major advances, or fortunately, thanks to this progress, we have 7 countries that have already received certification of this elimination. There are many challenges. In the past 2 years, countries in the region reported that we have over 30,000 cases of congenital syphilis. This condition has not been yet eliminated in the region. We're speaking of a disease that is not new, that shouldn't exist in our region. There is an extensive set of tools, technical guidelines, rapid tests, laboratory tests that are very sensitive and effective that may help both in the timely diagnosis as in appropriate treatment. At present, we will hear about some experiences that some countries have developed, particularly in relation to a case follow-up strategy. The necessary information for appropriate monitoring of cases may be obtained through the perinatal information system developed by CLAP. The perinatal information system is a versatile, timely tool for monitoring in nearly real time for prenatal and delivery care, and has developed to monitor indicators of vertical transmission of these conditions. The assessment of the information provided by the perinatal information system enables planning and implementing the best procedures to accelerate this elimination that all our region is committed to. It is necessary to focus on this as a genuine indicator of the quality of prenatal care to improve the quality of life of women and their newborns. In this seminar, apart from validating the use of the Perinatal Information System Plus in the assessment of syphilis transmission with good databases, SIP Plus will share a virtual online course to eliminate congenital syphilis addressed to health professionals in the first level of care. Our colleagues in the Caribbean will make this presentation and tell us about all this. So, welcome everybody once again. We hope that together we will be able to renew this commitment of the countries in the region towards the elimination of congenital syphilis. On behalf of Dr. De Francisco, thank you for your participation and very welcome. After these opening words and inaugurating this online seminar, we want to begin to share with you some of the elements that are part of the agenda we've prepared for today. Let us start then with a presentation on the state of the art that will be conducted by 3 regional advisors, one responsible for sexually transmitted infections, STIs, particularly HIV, hepatitis B, and INCLAP will also share some data and outcomes of the elimination from the standpoint of prenatal controls and some reports with recent data we will share with you. This presentation will be shared together with Dr. Ruben Majorga, Dr. Leandro Suarez, and myself. So, let us then start with the first part of the presentation. I want to introduce Dr. Ruben Majorga from the Washington office, who will make the first presentation. Ruben, the floor is yours. Thank you, Rodolfo. Good morning, everybody. Let's see the screen in the presentation mode. I'll try again. Thank you. Because I have 2 screens, it's not so easy. Good. Good. First slide, please, son. So, as Rodolfo stated, the issue of the elimination, well, first, duel of HIV and syphilis goes back to some time ago. We have a first resolution in 1995 from PAHO on the elimination of congenital syphilis alone. And then we have a series of developments at world and regional level that contribute to this effort. First, the rationale and action strategy to eliminate congenital syphilis at world level in 2007, and followed in 2010 at regional level by PAHO with the establishment of the goal of MTCT for syphilis in the region with this resolution, and establishment of a regional secretariat in 2011 and the regional validation committee in 2014. This is accompanied by global developments of this 2011 plan to eliminate HIV infections in children by 2015 and guidelines for elimination of MTCT 2014, the Orange Book we always refer to, and that is being constantly updated. In 2015, we have the first validation of mother-to-child transmission of syphilis in Cuba. That's the first country at world level, and together with the regional action plan for HIV and STIs with a syphilis component in 2016 that has been completed. Then in 2017-18, we had the validation of 6 countries in the Caribbean, like Cuba, Anguilla, Antigua and Barbuda, Bermuda, Cayman Islands, Montserrat, St. Kitts and Nevis, and in 2021, Dominica. Using as a framework the elimination framework for other diseases that are transmission, not only preventable by vaccines, but due to other infectious agents. Mother-to-child transmission strategy was extended, including hepatitis B and Chagas disease, that is added to this strategy of elimination of syphilis and Chagas disease. And then we have an initial PAHO report on the elimination of mother-to-child transmission published in 2019. And this year, we continue with the validation of the plus. We had a validation of the methodology to check the elimination of hepatitis B, where Brazil participated and were working on criteria for Chagas disease that we'll later see. And it was established that there would be a new regional validation committee after 2 years of lack of action due to the COVID pandemic. The regional framework ultimately comes with a series of technical documents that have facilitated its implementation, and the extended elimination, including Chagas disease and hepatitis B, is based on the lessons learned for elimination of mother-to-child transmission of HIV and syphilis. This necessarily needs coordination and implementation between programs in the HIV programs and mother-to-child health in the health ministries, but perhaps further ministerial instances, and make the most of the existing structures, particularly this large amount of documents and guidelines and tools and standard validation method. Of course, this requires commitment at high level in the political sphere, and to be successful must be strengthened, bearing in mind this in all mother and child health approaches and framed in universal health, of course. We here have the countries that have validated the elimination of HIV and syphilis as listed: Anguilla, Antigua and Barbuda, Bermuda, Cayman Islands, Cuba, Dominica, Montserrat, St. Kitts and Nevis. These are all Caribbean countries. In our region, there are others at a level, but our region is considered by the colleagues in WHO as a region that is in the front line. MTCT plus that includes HIV, syphilis, Chagas, and hepatitis B. The goal is to reach and maintain elimination of mother-to-child transmission of these 4 conditions in our region, and the impact goals are as listed. For syphilis in particular, less than 0.5 cases of congenital syphilis for 1,000 live births. There are others, for example, over 90% of children cured from Chagas infection as checked by negative serology post-treatment, less than 2% of mother-to-child transmission of HIV and 0.1 prevalence of HBsAg in children of 5 years of age. This extended elimination strategy is based on lessons learned for HIV and syphilis, but as mentioned, also the experience of elimination of preventable diseases by vaccination in the Americas and the documents for elimination of transmissible diseases elaborated by WHO and PAHO that have a lot of scope and a timeline for 2030 for this to work. It's essential to have political commitment. That is necessary because we observed that since 1995, we're struggling with this. We observed that in 2015, we had this commitment to eliminate this some years later, and we renew the commitment, but it's very urgent to focus on the elimination of HIV and syphilis in our region. We stated that implementation must be interprogrammatic, not depend only on the HIV program or only on mother and child health, because there must be appropriate technical and operational interaction, at least between both programs, with an approach at public health level to simplify and integrate and provide care to the user in the first level of care. Here we have the programmatic goals in general terms. The most important are to have over 95% coverage of antenatal care and hospital deliveries and under 10% of unsatisfied needs for family planning in women between 15 to 49 years of age. We will observe that both for HIV and syphilis and hepatitis B, we have screening coverage and of treatment over 95%. For HIV, the treatment is in pregnant women, in some cases in the child, and in syphilis, the same. Here. Well, thank you, Ruben. Well, I take the floor, letting you know about the new figures here. Thanks to Dr. Majorgo, we have unmet needs for family planning. That is one of the indicators for the process. Observe that in the South American region, this unmet need for family planning remained quite stable and lower in North America, but in the Caribbean it has remained essentially the same. Here we have the estimated number of pregnant women with access to at least 4 antenatal care visits defined as essential and observed when we think of the 14 million women that become pregnant every year. 12 million of these access to antenatal appropriate care. So we may say that they have contact with the health system. And likewise, most have institutional deliveries. This is a characteristic of our region. Being able to estimate how many of these women were positive for the HIV test and treated appropriately with antiretrovirals. Here, the difference between the Caribbean and Latin America shows a different behavior. First, the appropriate regime, and how in the orange line, you can see transmission throughout the breastfeeding period. This includes elimination of breastfeeding in cases where it has not become negative and may be replaced by artificial feeding. We see that the cases with effective treatment and coverage have managed to increase in time in the past 10 years, essentially in both regions. And this is, in my view, one of the most powerful, stronger information that shows how since 1990, when we started with this initiative for elimination of vertical transmission, over 50,000 cases of children And if this trend continued, would have been born with HIV. This 50,000 cases, well, as we grow in time, there's an increase of cases prevented where the mother's transmitting the disease to children. So it's very feasible, and I wouldn't say simple, but we're aware that the impact is highly positive. In the reduction of HIV transmission, it's very important in many countries. But if we observe what occurs with syphilis, the outcomes aren't so good. And thus we observe that women tested for syphilis, and of these, how many are reactive at serological level. We observe that in general, women tested for syphilis in most cases are tested both in the Caribbean and in Latin America. What we do not have is appropriate treatment for these women that are tested, are positive, however, do not receive the single appropriate treatment during pregnancy to prevent the newborn's infection, that is penicillin. Thus, we observe the number of women that were reactive in Latin America received treatment in time using data until 2021. Remember that the goal was that 95% of women that in the antenatal control were tested receive appropriate treatment. We repeat, in pregnant women, the only treatment has proven to prevent vertical transmission is penicillin. Observe this analysis of a 5-year-old period between 2015, 2016, and then 2020, 2021, as reported for syphilis prevention in pregnant women, and observe that in practically all Latin America, Central America, and South America. In the Americas, particularly Latin America, we observe an increase in prevalence of syphilis of tested women. This is a characteristic, and if they had appropriate access to testing and timely treatment, would allow us, independent of the syphilis prevalence in the general population, to eliminate transmission to the fetus and newborn. Of course, because it is higher, because syphilis is higher in the general population, probability of pregnant women to be positive during pregnancy, even receiving treatment and being infected by their couple, is higher. Thus, we observe that in the Americas, with this volume of 39 countries, the number of congenital syphilis cases and how this has been controlled initially, then stabilized, and then in the more recent years, we're seeing an increase of congenital syphilis. This is striking and must ring a bell, because we cannot continue working in the same way to have similar outcomes. We must work in a different way, in a renewed way, using resources such as rapid tests and monitoring systems, allowing us to reach a decision in real time and not based on a test conducted 2 years before. Thus, for example, we see the incidence of congenital syphilis 2009-2021, and how we can use this increase in Latin America, an orange, and the weight of this very large country in the region, Brazil, that is in blue. Observe the proportion that contributes to the number of congenital cases in the region by this single country. But we see this contradiction that although the transmission is very high in Brazil, it is falling. The number of cases falls, and in Latin America, it began to grow. So this effect that shows a positive increase already shows this paradox that Brazil is the largest country contributing that stabilized and reduced the rate, but Latin America is increasing it. This is very striking. Thank you. Now, Leandro, I hand you the floor. Yes, thank you, Rodolfo. Well, continuing this, I would like to share some components regarding the implementation of the initiative and the challenges to advance with elimination of mother-to-child transmission of the full conditions, taking into account syphilis, congenital syphilis. And regarding the conceptual framework as introduced, and the framework defining three main lines of action that are considered for the strengthening of the strategy that include comprehensive services. So the idea is to integrate services for the full conditions, to strengthen mother and child health and antenatal care, particularly when we identify and see the commitment at the highest level among the health authorities, the health ministry. Well, we require high level commitment because, as stated, it has to be an interprogrammatic task. So the higher the commitment, the easier the integration and the possibility of working to implement this at interprogrammatic level. It also makes it easier to guarantee human and financial resources. And as stated, the idea is that the services be comprehensive and integrated, because we're speaking of pregnant women and their children that are in the territory, and we may offer the necessary services to eliminate these conditions on all the occasions in which these women have contact with the health services. The second line regards strategic information, generating data that are also geared to the program, but generating information to respond to the indicators and validation criteria, because we recommend the implementation. We want to know the impact of elimination, but also want to generate information so that this impact be effectively assessed and later be acknowledged through certification of countries. So this activity includes definition of baselines, update of protocols, harmonization of the definition of cases, mainly for syphilis. There's a lot of discussion between epidemiological and clinical cases and the definition of these cases, and it would be also interesting to further improve information to generate different systems or research programs for cases, particularly with the goal of refining information, but identifying gaps in the system to improve this further. In the third line, we have the laboratory and the supply chain, and then mainly the idea is to use new technologies and to have diagnosis in the point of care, to facilitate the passage of the patient in the diagnostic systems, be it with the systems in the point of care, rapid tests for HIV and syphilis, likewise, diagnosis and treatment in the same consultation when possible, to make this simpler, and to strengthen acquisition systems as mentioned, so that we have the tests supply. This defines also the number of interventions. I'm not going to enter into detail of interventions, but the idea is that we have interventions for the different opportunities in the life course, particularly in mother and child health, before pregnancy and adolescence, providing information, access to services, sexual education services, access to contraceptive methods, etc., prevention measures, and also actions throughout pregnancy in the pre-antenatal period for the mother and child, access to diagnosis to ensure that the woman has a diagnosis, immunization in case of hepatitis, treatment, follow-up of the woman and child, and likewise cross-sectional interventions when we identify a child with HIV, hepatitis, or Chagas disease in a family. The idea is to search for other children, siblings, other family members that must be investigated to extend research and ensure comprehensive care to the family. As mentioned, the promotion we conduct has to do with the implementation of the MTCT program, bearing in mind appropriate testing to assess this process and progress of countries to validate them. Apart from indicators of programmatic impact, as mentioned by Dr. Majorga, initially we must take into account other pillars of MTCT, data generation, data, quality data systems, programs and services, their quality and scope, as mentioned, but also bearing in mind human rights, gender equality, and community engagement. And the fourth pillar would be the quality of laboratory services. And here's further items that are necessary for a country to be acknowledged and validated for these efforts. Apart from the indicators, bearing in mind that there are specific actions to respond to subnational administrative areas or subpopulations in the country with the worst indicators. It must be demonstrated that they're paying attention and working to improve these conditions. Surveillance systems and data are generated and must be extensive, taking into account public and private care. And once again, this is a component that is increasingly strong in the validation, certification, and implementation processes for the initiative, and that is participation of civil society. And briefly, challenges and next steps to advance. As I said, we must transform the political commitment to practice. Many countries were committed with the initiative to eliminate MTCT, particularly HIV and syphilis, but this isn't resulting in an impact as observed in the indicators shared by Rodolfo. We must review the commitment, strengthen programs, and invest on the elimination programs. Another challenge is vertical programs, particularly for integration of more recently included diseases, hepatitis B and Chagas disease. But we also observe that in many countries, we have this vertical part between the syphilis and HIV program with the same department, but the implementation is still not integrated information systems. We also have issues at national level, particularly with some indicators, and we have observed infections, particularly syphilis in pregnant women in the region. We need prevention before pregnancy. The idea is to make sure we have access to screening and treatment in women that are in a fertile period, healthy reproductive health, and we won't impact on mother-to-child transmission for HIV and syphilis if we don't have a joint response to reduce prevalence in general terms in the general population, and mainly in this population, because these epidemics are considered of different populations but are related. And if we don't work in an extensive way, these different components of the epidemic will not reach progress in the region. Next steps require expanding the diagnosis. The recommendation is that we use and make the most of the new technologies with simplification of algorithms, making the most in the point of care with technologies to simplify the diagnosis, guaranteeing quality and supply, and the procurement chain of supplies, so we don't risk having failures of availability of this input. Once again, strengthening human rights, gender equality, and community participation, and strengthening availability of PAHO WHO to support countries in the implementation of this initiative with technical cooperation mainly, sharing experiences of countries that have made more progress or that are implementing innovative approaches for this initiative, and mainly with this possibility of encouraging a discussion in the countries and at regional level of the different members interested in the initiative. Thank you so much. Thank you, Leandro. Here you had this overview on the status of the Americas elimination of congenital syphilis in the context of the elimination of the 4 diseases. Now I invite Dr. Mailera that will speak of an instrument, the perinatal information system, SIP+, that has an innovation for near real-time monitoring of this condition. The floor is yours, Luis, please.
Okay, gracias, Rodolfo.
Thank you, Rodolfo. Good morning, everybody. Allow me to share the screen.
¿Se ve bien, Rodolfo?
Can you see it?
Perfecto, muy
Good, yes, thank you. Nice to be here. I know that we have many colleagues connected. Thank you to the SIP team that prepared this presentation. I had to present it today. We had a health problem in one of our colleagues, so I am helping out. Now, continuing with what the colleagues were saying, part of the SIP Plus, MTCT Plus, is to strengthen surveillance, monitoring, quality of information to provide throughout pregnancy better planning during gestation, postpartum, and with control and follow-up of newborns exposed to some of these diseases. In this sense, SIP and advancing has a major quota of security. To share with you something that isn't always clear in the presentation, and that is that the information managed in SIP Plus is stored in the countries. We don't have access to this. The SIP Plus software doesn't send the information automatically anywhere where the health authorities in the countries require it. So, knowing this, we make sure that SIP Plus is very safe in this regard. Safety is responsibility of countries, and as we said, CLAP has no access. This is a very complex and sensitive issue, particularly for the topics we're currently discussing. The perinatal clinical record that you know has, in general terms, this possibility of recording the woman's diseases during pregnancy. At left, we have Chagas disease, here, hepatitis B, and lower down at left, the HIV diagnosis before and after 20 weeks, and the diagnosis of syphilis before and after 20 weeks. This regarding women during pregnancy. In the antenatal consultations, for those who are aware of the perinatal clinical record, they know the screen, they can upload As we can see here, VDRL in the first consultation, treatment is installed, contacts are treated, and then in the following visits, we observe how it falls. This then throughout follow-up. Finally, during labor, we have the possibility of uploading information in the rapid test here at right. In green, we can upload during labor data for syphilis and HIV, and if the patient was or not treated. Last, at the time of caring for the newborn, we have in SIP this possibility of also recording neonatal screening, VDRL, and here also Chagas, and if the patient was immunized or not for hepatitis B. So as we saw in these past images, in the clinical record, we have several places where we can record the information, both for the woman during the visits or the newborn at the time of birth and discharge. SIP Plus may also provide other things as mentioned today, that is to have a list of the newborns with some of these data positive at the time of testing, to conduct follow-up after discharge, calling the mother by phone and so on. And we will have a short live presentation how to proceed with SIP Plus in this sort of case. The clinical record then wouldn't be closed. So at the time of contacting the woman, we can bring back the information and complete the information that is missing, and SIP will automatically record it until it is definitely closed. SIP has very innovative things. People mentioned some already. Here we can see the issue of the lack of information or the delay in recording the information. This occurs throughout. We don't have any country free of this sort of thing. And a possible solution would be to relate SIP Plus to these other systems providing health information according to a concept we will later elaborate on. An example is then that vis-a-vis a positive VDRL, be it that the lab or institution have a positive result. This is just an example. The information will automatically be sent to the pregnant women for her to anticipate and have it visible in her clinical record. In this sense, this schema tries to explain that SIP Plus has numerous manners of communicating with other health systems within what would be an integrated electronic health system at national level. It may communicate with live birth certificates, contraception, vaccines, and labs. It is perfectly easy and obtain the information back and import it to SIP. We have some examples in the region, not specifically for this, but yes, examples that maybe will be discussed this morning, such as one we're working with the colleagues in Trinidad and Tobago, where SIPs, and I won't enter into details, but connects directly to give follow-up to women victims of violence, and the development scheme is what we're proposing right now for the lab, be it for VDRL test, HIV, or whatever. It may obtain information from other systems and bring it automatically according to this umbrella known as eHealth. SIP Plus, and this was already discussed, comes with the possibility of conducting automatic reports. And automatic reports in SIP Plus are some of the indicators, apart from those already mentioned. We'll give examples now. This is a SIP plus screen you may enter, and after my presentation, I will include this in the chat so you can try it out after this conference and see how it works. You may obtain a report of those who were speaking before, a report with a single click where you can have all the transmission indicators for the prenatal clinical record. You'll have impact indicators, others related with primary prevention, sexual and reproductive health, diagnosis and treatment, and of course, specific for the 4 diseases selected as included as MTCT plus indicators. What about the format of these reports? Grossly speaking, as shown here, with some data that are useful for us to give traceability vis-a-vis problems, software, the records, and if there's an issue, you can consult the SIP team. Also, response to countries in this sense. We have many examples, and of course, this example of MTCT plus indicators is what we see in this presentation.
According to its format, we try the indicators to be issued always the same so that it will be easy to read, and you have the title of the indicator, the description, the total, and if appropriate, the rate or the percentage. This is another example where you can print the report. You can print a PDF, a report, you can cut and paste, you can export it, everything that you know that can be done with computing today. So, completing this part of the presentation, let me give you a live presentation, a demo. It's working in a lot of countries. There in some they use the perinatal clinical record and other the neonatal that of abortions, contraception. So SIP Plus has a great coverage in the countries in the region. The countries that are still using the old version, the Windows release, that is some years old, little by little we're trying to migrate to this other version because it's much more friendly, user-friendly. So it's much better. Let me now change. I'm going to shift to show you the software. Let me show you a live demo. I'm going to enter a test database. The data that you see is just for training purposes. So we are not representing any countries or any institutions. This is just a test database. So you enter with a username and a password, and on top I'm going to give the presentation in Spanish, and I apologize to the English speakers, but up here you can choose select the language that you want to work with SIP. Just for today's purpose, we're going to do it in Spanish. So you put the username and the password. This is for safety purposes. You have to validate the username. I'm going to enter with the administrator's username because so I can show you the full potentials. This is the home page of the software. Here, up here, in this precise moment, this is synchronized with 1, 2, 3, 4, or 200 computers. It's a demo, but when you're working with a centralized software, it is important to know that the software is connected to the centralized server. That's why it's in green here. The software has a lot on the website. You have the instructions that I'm going to show. You can look for records with an ID, or with the patient's names, or directly by pressing the search button. Oh, please, could you, we are running out of time. Yes, so I put search, and here you have the clinical record of SIP that you all know. Now, to show you something of what was mentioned today, with SIP, we can filter. You see the VRL, and I'm going to ask SIP to please filter the screening messages that were positive. Here, the listing. Here you see these 14, 15 medical records that appeared, and it is there where the screening of the newborn was positive for the VRL. So I can put the, I can open the record, I can see the telephone number, I can call the patient, so you can fill in the data of SIP+. And it is here that the screening of VDRL is positive. I'm going to delete the selection. And finally, let me show you where we have the report. Here you have the report option, the automatic reporters indicators for in the plus, and the report that appears here automatically and that you will have a chance to see later. It is there that you have each indicator that, each one of the indicators that were mentioned by the previous speakers. These reports can also be drawn for a specific population. For instance, I could say that I want a report including the women under the age of 19. I could draw the same report, and if you pay attention here, this is for 18,000 pregnancies, and when I issue the report now, it's going to do it only for 1,600 patients, 1,700 pregnancies, and here on top you see it where SIP shows that the same report with the indicators that we're looking at were drawn for the group of teenagers. So this is very simple to use, and with this I'm done. In the website www.sipplus.org, it's available in English and in Spanish. We have some useful documentation, and you have 3 videos in Spanish and in English showing a summary of SIP, and then an example of how to enter the SIP medical records, and the 3rd video is an example of how the reports, SIP reports, get done with the software. It's with what we just showed. I don't know, Rodolfo, whether you want to add anything on this report. It's, well, what you just said is absolutely wonderful, and we thank Luis and the SIP team here represented by Luis Mainero, but there's a whole group of people led by Giselle Tomaso, who unfortunately couldn't be with us today, but thank you, Luis. There are many questions in the chat as how to access this record, and I think that Luis, in his last slide, showed the SIP wiki, how to get in, where you find the site, and there you can go in and find all the data. And if you have any doubts, we are available to walk you through this decision. Yes, I'm going to paste it in the chat. Yes, thank you. It's precisely what I was going to say. Yes, thank you, so that the colleagues after this presentation may take a look at our website and find the information they request. There you have the answer to many of the questions that were mentioned. What is the latest version, the updated version of SIP+, etc. Now, without further ado, let me introduce the next table led by Maria Angela Freitas, our colleague who has collaborated very closely with CLAP, developing all these tools. And it's a great honor and it's a great pleasure to have her with us today. Maria Angela, you can introduce your people. Good morning, everyone. So now, let's start this table where we have 3 countries, actually 4 countries, that are going to present their experience with SIP+, using SIP to access the data of syphilis transmission, congenital syphilis in their countries. So initially, let us start with Peru. I don't see the chart. Could you please put a slide introducing our colleague from Peru? Thank you. So let's start with Kelly Ceballos. Dr. Ceballos is going to tell us about Peru. Kelly Ceballos is currently the head of the Epidemiology Office and Environmental Health in Lima. Kelly, you have the floor. Good morning. Can I share the screen? Yes, you may. Can you see it? Yes, yes, we can see it. Yes, perfect. Presentation mode now? Yes, good. Good morning. Good morning. I want to thank the invitation and all the audience. It's for me a great honor to be at this meeting and to be able to contribute with the aim of this meeting. Let me tell you about the experience that we did at the maternity here on congenital syphilis from 2018 to 2021. The epidemiological profile of maternal congenital syphilis at the Perinatal National Institute in Lima. The objective was to determine the epidemiological profile of cases reported of maternal and congenital syphilis at the Mother and Perinatal National Institute. The methods used where this is a secondary analysis of data obtained from SIP from 2018 to July 2021, including data of 1,050 pregnant women with maternal syphilis and 224 newborns with congenital syphilis. The results, the prevalence of maternal syphilis during the period of study was ranged from 0.94 to 1.77 of the social demographic characteristics in mothers with maternal syphilis. The most frequent ages were from 20 to 34 ages, and a similar percentage from 71.42 to 74.45 was similar to the group of pregnant women with no syphilis. However, there was a statistical difference in the group of teenagers, adolescents. At the secondary level, it was more frequent in both groups, with percentages over 67%. And the marital status was greater in the single women were more frequent among the girls with syphilis, and 98% came from Lima, and the use of and the lack of use of modern contraceptions was greater, and more planned pregnancies was there. You have the figures. The incidence of congenital syphilis is there. The conclusion is the prevalence of maternal syphilis has presented an increase from 2018 to 2021 of 0.94 to 1.77, and congenital syphilis from 4.06 went to 5.8 respectively. So we realized that 2020 and 2021 led to an increase both in maternal and congenital syphilis. That is probably due to the fact that during the pandemic, the first level centers were closed and it was more difficult to go to seek care. The methods used for this work were the Syphilis database. We entered the data of the patients with syphilis in this format, as was just mentioned by the previous speaker. Here you have a highly enriching data that gives you a lot of information. And we have the antenatal visits, the history, the data of the screened newborn, the treatment, postpartum, and, well, the findings with the use of SIP enable us to establish adequate flows for filling information, and we can ensure the monitoring of a timely treatment for the mother and the newborn, and to identify the cases of congenital syphilis, and to provide a timely and adequate treatment so that you can trigger the alerts of the multidisciplinary team of HIV and STIs at our institution, and to monitor and ensure the start of the completion of the treatment. We can also analyze the indicators to reinforce preventive attentions and to reduce the prevalence of maternal and congenital syphilis. We can also use the indicators for generating the operational epidemiologic research. What other systems have we used for this work? Well, we have a system that is INMP with the monitoring the care and identifying and delivering the treatment, and the CIAN is a system that enables us to complete the data of the child exposed immediately after birth and relating it to the mother's data. Other systems, we have the epidemiological file of HIV that we enter the notification of a report of cases of maternal and congenital syphilis at a national level. It won't let me go any further. Another system that we have used is the nominal pattern that we have that allows us to monitor the maternal and congenital syphilis that are reported to DIRIS and this to the Ministry of Health, MINSA. What are the strengths of using SIP to analyze the congenital syphilis indicators? Well, it enables us to unify and to analyze the results with the rest of the Latin American and Caribbean countries in the sexual health and reproductive area. It handles a complete information system, and we can monitor the cases. We can continue with the monitor of the children with syphilis, congenital syphilis, and plan their care. We have reliable statistics, and it facilitates the audits of congenital syphilis at our center. It also allows us to analyze and compare the results with other institutional information systems such as CISGALEN, CIAN, and the nominal pattern. Establish a surveillance system for congenital system and syphilis, and to identify the weaknesses so that we can organize training. What are our challenges? Using SIP for the analysis of the congenital syphilis indicators, implement the SIP in all the centers at all levels of care so that we can have a connected network, and to add indicators to enable us to monitor the children that die within the first 30 days of life, that it's not available in SIP. So, future steps. We believe that we have to assign technical training and to handle data and to allocate a budget to invest for the staff and logistics for the proper filling of completion of SIP, and to establish new strategies for the early diagnosis and a timely treatment for syphilis in the country. Thank you. Thank you, Kelly. Thank you for giving this very good presentation. Of course, there's a lot more that you would be able to tell us, but thank you for this evaluation. And I, from Peru. Now, in the next presentation, at the end, we'll have some comments. And the next speaker is Dr. Cristina. Maria Cristina, we call her Cristina Cipolla, who at present is the coordinator of the Perinatal Health Directorate. Cristina, good morning, can you hear me? Yes, yes, perfectly well. Good morning, everyone. Thank you for giving me this chance to share with the rest of the countries and with so many experts to share the data of the Ministry of Health of Argentina. What we want to show, we had two objectives. First of all, we analyzed indicators related with syphilis, and we took the indicators of the positive test, treponemic or non-treponemic, and at some time of pregnancy of the population that we included in our study, and also among newborns. These databases we work with are the ones that are registered in the SIP in the centers of public centers, and the period was from 2015 to 2019. Having analyzed many indicators and others that we won't mention now because it would be a very lengthy presentation, we started to focus on the quality of data, and our aim was to analyze the quality of data depending on the centers that we had entered in the database. So we established a criterion for good quality of data related to the healthcare centers. Now we're going to tell you how we did it. The first step was to consolidate the databases of the 419 public centers of the country, of 24 jurisdictions, that is 23 provinces and the city of Buenos Aires, and the period was 2015 to 2019. And with that, we gathered the registries of SIPA of 1.5 100,000 births, and we built indicators, variables, and categories, and we use SIP Gestion. That's a set of indicators where every year we report as a choice, a pick of important indicators that have to do with perinatal impact. And with this, we conducted a methodological analysis of the quality of the data for the positive test. So the first thing that we checked was coverage of SIP with regard to the data of our country. As you may see here to your left in the chart, the births go down as years go by, but live births also drop, both in the public sector and in the private sector, in all the hospitals in the country. And if we look at right, the chart of coverage, you see that it was always over 73%. So the coverage has been quite stable throughout the period. Now, we said that we had conducted an analysis of the quality of data because as we started looking at the indicators, we wondered whether there were any differences. And we saw that if we saw the type of center that registered the data might have different qualities. And we started to see that the largest maternities, the large maternities with over 1,000 up to 5,000 childbirths per year were the ones with the best quality. So we established a criterion to say which were the centers that we would choose as good quality. And we considered two criteria. Concerning this indicator, that is positive test for syphilis, that was built with this motto: all pregnant women that during pregnancy ever had a positive test for syphilis, treponemic or non-treponemic, and that either in the first 20 weeks or in the last period. And if there was a lack of less than 15%, that was considered good quality. And on the other hand, if that variable of positive test in the pregnant women was syphilis in the pregnant women was zero, that is, that they didn't have any records or over 20%, it was not a credible piece of information. So with those criteria, we selected centers. Of the 419 that we had originally, we selected 178. That is 42.5% of the centers. Now, if we look at it, considering the births, there was almost 1 million childbirths, that is 61% of the cases included. And here, what we're going to see is the indicators, and we look at the data, the centers selected over the total. So here we can see the positive test rates for syphilis among the pregnant women, and to your left you have the trends from 2015 to 2019, and you see that there's a drop. The positive tests of pregnant women in the total, we started with 8.4% and we reached 4.5%. Now, if we look at the same variable, how it behaves in the centers with good quality of data, you see that the behavior of the values differs. Although we reach a value in 2015 that is, for 2019, that is quite similar, 4.1 to 4.5, we see that the prevalences are lower. And the same applies when we look at the pregnant women treated. Here we have to clarify that in Argentina, there's no lack of availability or access to penicillin, and the delivery of penicillin for treatment is free of charge at all public centers. Now, if we look at the data in all the centers, the trend is quite positive, or rather, we have good outcomes because it's almost all of the pregnant women that were positive were treated, 94%, and the behavior in the good quality centers reaches more or less the same value, but with some ups and downs. Now, if we look at the other variable, that would be congenital syphilis, when a newborn appeared in SIP with a positive VDRL, that maybe it may not be the same as a clinical diagnosis, but it is what SIP tells us, and it's what this system allows us to have. We use the traditional SIP, not SIP plus yet. So in all the centers, we see that from 2015 to 2018, the percentage was quite stable, and there's a big increase, 2.8 in 2019. Now, when we look at these values in the centers selected because of the good quality of data, we see that the shape of the bars is similar, but the percentages are a bit lower. Now, in 2019, we have a remarkable increase in children with congenital syphilis. This can be interpreted in different ways. We have discussed it with different teams at the ministry. There are several hypotheses. Now, what we think that there are several things that could account for this. The quality of data improves with time. But in addition, the quality of the records improve with time. And maybe, too, prioritizing this topic in recent years have led to an adjustment of the quality of data. So although you may have we said that the treat therapy was accessible and it was improving, why do we have more congenital syphilis? Well, there may be an overdiagnosis, so we may be reporting more cases. Now, the conclusion is that we had more conclusions than this, but we want to highlight some aspects. This poses a challenge. And as a country, we are going through the process of implementing SIP Plus in all the country. There are some centers that are already implementing it, and this is going to be a new stage of SIP Plus. And as a matter of fact, there are some provinces that are even relating SIP Plus with the medical record, with the usual medical record of the population at their healthcare centers. We believe that the first challenge is to strengthen the first level of care. That entails a great responsibility in all the strategies for everything that needs to be done to eliminate congenital syphilis. We are rather far, but we think that by strengthening the first level of care, both in care and in the production of data, those could be among the first things we have to do. We know that we have to improve the quality, the timeliness, coverage, and accessibility to data, also within care, and that the data may become a tool for perinatal care. And finally, we also think that the implementation of SIP Plus, comprehensive in all the centers, and this would also include healthcare centers of the private sector. So before we can say, refer to the entire country. So, and we are convinced that this will lead to a better quality of care, because we will make decisions for management, both in micromanagement and meso and macro management, something that is essential, that is using the information available. That's all. Thanks a lot, Cristina. We are aware that it's not easy to condense all the work, but thank you for the presentation. We got a good idea. So now we're going to listen to Paraguay. This work was in Paraguay. Patricia Velar is going to tell us about the work. Patricia Velar is the head of the Department of Pediatrics. I don't know why they removed the slide. So Patricia will present the data of Paraguay using the Syphilis data. But Dr. Ovelar, good morning. I'm Patricia Ovelar, and today I'd like to present the work, a study on the situation of congenital syphilis in Paraguay using the data provided by the perinatal informatics system, Syphilis. This is a preliminary report, and we are adjusting it. Let me start by saying that in Paraguay, syphilis continues to be a public health problem, in addition to being a challenge to succeed in eliminating the mother-to-child transmission. In an AIDS monitoring in 2020, Paraguay reported the coverage of screening for syphilis in the pregnant women was 72%. Please remember that in Paraguay, the rapid tests for HIV and syphilis and hepatitis B are distributed across the departments, from the family first levels of care to the tertiary, but our coverage even continues to be low, 72%. And the pregnant women with a positive test, the treatment with penicillin was 56%, 56.1%, according to this global AIDS report. And penicillin in the country is also delivered free of charge, and it's also distributed in all the centers. In a study in 2018 with a national program in cooperation with PAHO, we used a tool to estimate the burden of congenital syphilis, and every 9 children, 1 was reported. So out of 9 children that we estimated are born with congenital syphilis, only 1 is reported. So we believe that there's an underestimation of the congenital syphilis burden based on the surveillance data that may lead to a loss of opportunities for the diagnosis and the treatment of children. In that same study, the prevalence of syphilis in pregnant women was estimated in about 3% in 2018. And the estimated rate of congenital syphilis in that study per 1,000 live births was 17.92%. That is a high burden of congenital syphilis in the country. So we wanted to analyze the data generated by Syphilis to build the indicators of the elimination of congenital syphilis, to see whether we could also use the data in Syphilis on congenital syphilis and HIV. So we determined the completeness and consistency of the data produced to build these indicators. We also evaluated the factors associated with congenital syphilis, and we determined the progress for the strategy of elimination. We conducted an observational retrospective cross-sectional study representative of the entire country using the data produced by Syphilis of the mother and child centers of the Ministry of Health, where the pregnant women go for their antenatal controls. We gathered the data generated by Syphilis from January 2018 to July 2021, and We included all the medical records in Syphilis in nominal format that were analyzed to be able to determine these indicators of of syphilis transmission. And here we have all the indicators available in a one-click tool of Syphilis, and we can. And here you have these the context, that is mother's age, marital status, etc., and all the accessibility and those related to the diagnosis, treatment, and monitoring of syphilis and impact. As you are aware, Syphilis in Paraguay we started uploading it systematically starting in January 2018 in the different departments of the Ministry of Health, where these pregnant women for their antenatal controls. We had 32,479 medical records, nominal by name of the pregnant women from 2018 to July 2021, and to see, and we considered the number of births registered in the country, and we used this denominator because we considered that this was more robust and reliable. Because if we used the number of pregnant women, we could have duplications. And in addition, we had a delay in the number of pregnant women in the departments. So we started to use this denominator. And we could see that as years went by, in 2018, when we started to upload them, we started with 1.5. By July 2021, it was 23%. Now, to be able to determine the percentage of information ignored per variable used, in context, we saw that it's the variables with less loss of information. Here you have it. And the ones with more information ignored, it's essentially those related to diagnosis and treatment of syphilis. As you can see, in 2021, we could see more information ignored. Now, to look for the factors associated to congenital syphilis that were statistically significant, we had adolescents. That's a risk factor. And determining the annual rate of congenital syphilis of our medical records that were loaded, we can see that although the burden is not very consistent, we can see a high incidence of congenital syphilis that is also matches, is consistent with a study that I mentioned, where we saw that the congenital syphilis rate per 1,000 live births was 17. However, if we consider the number of births in the country, we see that this incidence is almost the same to that reported. So it is very important for uploading the data is essential for Syphilis, and we saw that it has many advantages to use this system and to draw the indicators of the STIs. And we could conclude that there's an underestimation because of lack of data. We improved the percentages in 2021, but it continues to be low. The ignored data, we could see that essentially 2020, but we assume that it is because of the pandemic. In May 2021, the Ministry of Health and Social Welfare presented a regulatory framework to use and to upload Syphilis in the mother and child departments of the hospital. And at present, we've seen a significant increase, and the variables related to context are loaded in, are included in many, but those included to STIs and syphilis continue to have a low percentage. We find a high incidence of congenital syphilis in the data that we have, and the adolescent age is a risk factor. It's very important to continue with sustained training of the staff, current staff, and to ensure that the information systems may be uploaded and used correctly, and promoting the use of information in the health of women and perinatal to support medical actions, and to continue to train the healthcare professionals for the diagnosis of syphilis in pregnant women, using the criteria of congenital syphilis in all the departments of the network of the Ministry of Health, because we also believe that very often this definition of cases of congenital syphilis very often varies, and also to strengthen the monitoring of the mother and child so it won't be lost during the cascade of services. And we consider that it is very important to continue with the analysis of the indicators of STIs and syphilis that are generated in SIPLA, so that we can see the progress as years go by. Likewise, something that I consider that is very important is to determine sentinel centers, especially in the departments where there are more childbirths, and to determine in those and to evaluate and to monitor in those services how people continue to upload SIP+ in those places. And another piece of information that is important is integrating SIP+ with the syphilis surveillance system, the SEPRONACIDA, that where we have a lab module, and so we believe that it can facilitate the identification of congenital syphilis. Thank you. Thank you, Patricia, for your presentation and for your work in Paraguay. Now, Dr. Adesh from Trinidad Tobago will tell us about their experience with SIP in the country. He's the coordinator of the area of women's health at the Ministry of Health in Trinidad and Tobago. He's the director of that unit. So, Dr. Adesh, please.
Thank you very much. Actually, I was supposed to be giving some comments on the presentations that occurred. So I'd like to say thank you to all of the countries that presented, Christina, Patricia, Kelly, for their countries' experiences and the excellent interpretations and discussion of data presented. For those of you all who are not aware, we are just a small country in Trinidad and Tobago. We just have a small number of annual deliveries. We have approximately 15,000 annual births. And we have some very similar challenges that you all have stated, especially as we have all noted with the quantity and quality of the data being input into the systems in order especially to seek validation. I note earlier, we noted several of the smaller Caribbean countries with much fewer deliveries who were able to successfully seek and obtain the validation. I also note that the presenters gave some solutions and their conclusions where they, what they have offered. And I, of course, will take that and explore it with my team here in Trinidad and Tobago to see if some of these things can be implemented. We have very similar issues, especially something as simple as failing to adhere to clinical guidelines and policies. We have challenges at times in our small nation getting reagents. We have a really acute shortage at times with simple things like penicillin and access to penicillin. And we have been counting on the support from the PAHO in order to obtain these supplies. So that is always a challenge. With respect to the SIP, and Louise mentioned this, we're working closely with the CLAP with merging the laboratory with the patient record. So that will be a seamless process in moving forward. We are starting with the diabetes project here in Trinidad and Tobago. So that's important. We also have one other challenge that I'd just like to mention here in Trinidad and Tobago. So we actually have a significant migrant population. And although we give free access to antenatal care to our migrant population, we are seeing a number of our patients turning up for delivery for the first time with very limited antenatal care. And we are seeing quite a few positive cases as well. So those are just some of my comments. And again, I'd like to say thank you for giving us this opportunity. Over and out. Back to you, Maria.
Thank you very much, Adesh. Thank you for your comments. I would like to, yo voy a llamar a la doctora Gloria Aguilar de
I'm
Paraguay.
going to call Dr. Gloria Vidal from Paraguay, who wants to give you a brief comment about what Patricia said in the situation of her country. Gloria, please. We have 1 minute, Gloria, just to activate, enable your mic so we can hear you. It's a pleasure. Go ahead. For some reason, she's not being able to do that. Well, anyway, we thank the 3 countries. Thank you, Maria Angela, for being with us in this analysis of the reality of these 3 countries that you saw. They're quite different with different degrees of progress in the use of SIP+. And I think that you have illustrated it very well. Now, I have the pleasure of presenting Sandra Jones of the Caribbean Regional Office of PAHO that will present a proposal of a PAHO as built with working with the several departments of organization, a proposal that this is barely an announcement of something that is about to arrive. So, Sandra.
Hi, good morning, and thanks to all the participants that have joined us for this event today. Thanks for joining. I want to take a few minutes before we conclude this webinar to inform of a regional training on the clinical management of the seropositive pregnant woman and the exposed infant, as was just alluded to by Rodolfo. As countries in the region advance with the elimination of the mother-to-child transmission of HIV and syphilis, PAHO received numerous requests over the years for the training of healthcare providers on the clinical management of the pregnant woman with syphilis, and the exposed infants. And one such country was actually Jamaica, as they saw the critical need to strengthen the EMTCT services within the maternal and child health platform. And so as a result, the PAHO country office in Jamaica, along with the PAHO sub-regional office for the Caribbean, we collaborated with CLAP and colleagues from the PAHO regional office in Washington for the development of an online self-learning course that is expected to address the requests of the countries. So for the past 12 months, a group of experts, including CLAP and as well as experts from Jamaica, worked very hard to actually try and make this e-learning course a success. Next slide, please. Very briefly, I will just share that the e-learning course, it includes 3 different modules, which basically focus on the definition of syphilis, the screening and the treatment. Those are highlighted in module 1, and module 2 look at the definition of congenital syphilis, what is used for EMTCT. It summarizes the clinical signs of congenital syphilis and the different diagnostic methods. And the 3rd module outlines the importance of couples testing of the partner of the seropositive pregnant woman, as well as what it is that should be done for women who are allergic to penicillin. It identifies how to identify allergic reaction, and it summarizes the process of desensitization to penicillin. Next slide, please. At the end of each module, there are case studies that present different scenarios that allows for the reflection on the materials covered, and it analyzes the appropriate interventions. At the end of the course, participants will need to take a short test and pass the test before receiving a certificate of completion. Next slide, please. The training helps to reinforce the clinical management of syphilis in pregnant women and exposed infants, and by extension, it renews the commitment of countries in the region on the elimination of congenital syphilis. Next slide, please. So very quickly, the course is expected to be available in August. It is available in 3 languages, in English, in Spanish, and in French. And the information regarding the launch of the course will be circulated to all the countries via the PAHO country offices and our website. And we invite everyone to be able to participate in the course by registering on the virtual campus. And we have the link here on the screen, and the link will be shared thereafter as well. Next slide, please. And this is my last slide. So thank you very much for your attention. And we really do look forward for your participation in registering for this online e-course. Thank you very much. Thanks for joining us.
Muchas gracias, Sandra. Gracias en nombre del
Thank you,
equipo.
Sandra, on behalf of the team that has worked with contributions from different countries in the region, both in the Caribbean and Latin America, and some of the people you have heard today also that have helped us to detect the needs and the most frequent issues, and also possible solutions that we will share in August when we release this course. We thank everybody's participation and enthusiasm. We are 8 minutes late already. We're grateful for your patience, and we thank Dr. Seruja and Dr. Majorga that will make the closure of our seminar. The floor is yours, Dr. Seruja. She's muted. Thank you, Rodolfo. Thank you, Ruben. First, I want to thank the 200 people with us and have been here with us nearly 2 hours. We're discussing a very fundamental topic for women's health, newborns, a matter of rights, where we have the tools and indicators and political commitment, and therefore may deal with to make progress. Some countries in the region have already eliminated vertical transmission of both syphilis and HIV, so we know this is possible. That is my first message then. In this meeting, we wanted to share with you, and that's why it took a bit long. We had several presentations, that there's a toolbox both for diagnosis, for politicians, indicators, and elsewhere. And most important of all, we have this free of charge access tool. That's the implementation cycle that the countries are using in a wonderful way. So I thank the 4 countries, Peru, Argentina, Paraguay, and Trinidad and Tobago. I don't have more time to share all the brilliant things you mentioned from Luis, who shows that we may have this indicator linked to the lab systems and the patient records. I would like to add that many years ago, a country that has been treating syphilis in a very careful way, that is the US, conducts women controls in the labs. if there is a case of positive syphilis in a lab, the lab is responsible for following up the woman until the end of pregnancy and the birth of the child. SIP enables this, and countries have proven with brilliant examples in Peru, Argentina, with all the wonderful monitoring they will monitor and implement, and Paraguay, and ultimately what we're seeing already in Trinidad Tobago with another example, diabetes during pregnancy. That is that we have the tools and the possibility of doing this. And to make it better still, with us we have this course that Sandra has just introduced. And why are we thinking of an online course? Because we always have this need for updating and have this very much alive. Having a pregnant woman with syphilis is acceptable. Having a newborn with syphilis is no longer acceptable. It's a matter of quality of care. It's a matter of justice and rights. So we hope that everything that has been shared at this meeting be made a reality in the countries. And this depends greatly on you who are listening to us. So I end thanking this great team that prepared the meeting. I can't give all the names, it's many people. The Transmissible Diseases Department that has been working together with us for long years to make the countries participate, the countries, the lecturers that were all wonderful. And I hand the floor now to Ruben. Thank you, Suzanne. Ultimately, I also wish to thank all the participants that have remained nearly 2 hours with us. And the truth is that I make a call to assume this political commitment to eliminate syphilis, not only congenital and maternal, but eliminate syphilis, because ultimately we've seen this increase in syphilis in pregnant women and newborns, and we have managed to reach this 95% of screening and treatment we mentioned in the program indicators. Furthermore, the information systems such as SIP Plus are not being used everywhere. Furthermore, there is good news. Maybe some countries have already managed elimination, but they don't have the information to verify this. However, I'm sorry to say that unfortunately in many countries, we're not really reaching the actions needed to eliminate this. So as Suzanne said, indeed, we need to coordinate at least among the areas that technically support with new technologies and guidelines for immediate treatment of HIV and syphilis and everything with diagnosis, because we know that if the person has a late diagnosis or is seen at a later visit, this will not have an appropriate treatment. That's why we worked so hard to have double syphilis and HIV tests with immediate diagnosis to initiate antiretroviral or penicillin treatment immediately, because this is what is delaying us and making women and children fall in the gap and not reach this goal of 95% we're pursuing. So I make this call for us to truly eliminate mother-to-child syphilis transmission. I think that with hepatitis B, fortunately, we're quite advanced because most countries in the region have children intensive vaccination programs. But I think that there's work to do. And I hope that SIP Plus will support us technically in this regard, so that in the countries we will have good news soon. Thank you. Thank you, Dr. Cerruja and Dr. Majorga, for your words that syphilis with enthusiasm and commitment. And to close, I would like to tell you that to end this seminar, we invite you to see this very short video that will convey the message of commitment, enthusiasm, renewing the power of this agenda of this disease that can be eliminated soon if we all contribute. On behalf of the organizing committee of this seminar, we thank you, and please, let's see the video. Thank you.
Cuando una madre con sífilis le pasa la infección al bebé durante el embarazo. En la región de las Américas se reportaron en 2020 30.338 casos de bebés con sífilis congénita. Si se detecta a tiempo, es una enfermedad que tiene cura con un tratamiento accesible, muy seguro y de bajo costo: la penicilina. Se recomienda el testeo de todas las embarazadas en 3 momentos: al inicio del control antenatal, antes de la semana 20 y después en el tercer trimestre. También durante el parto si la mujer no fue testeada anteriormente. A su vez, es necesario tratar a la pareja de la embarazada que fue testeada positiva para evitar la reinfección. Los Estados miembros de la OPS han asumido el compromiso de impulsar en la región la eliminación de la transmisión materno-infantil, ETMI, de la infección por la sífilis con la eliminación de aquí a 2030.
So we end the seminar. You'll all receive the report and the recording of this session. Thank you. Have a very good weekend.
Muchas gracias. Hasta